Welcome everybody back from the break. I hope you had something nice to eat and a bit of a chance to stretch your legs. My name's Emily Banks. I'm an epidemiologist and public health physician. I'm a member of the annual meeting steering committee, and I'm also really pleased to be here welcoming you to this last part of the meeting. I'd like to start by acknowledging the traditional custodians of the land that I'm on. That's the Ngunnawal and the Ngambri people, and I'd like to pay my respects to their elders past and present, and to thank them for the privilege of living on these beautiful lands and working in partnership in health. I'd like to also thank our event sponsor, Bellberry, and I understand a video was shown during the break about the work of Bellberry. The next session is a really exciting one. It's about implementation of research to maximise impact on health. And I'm absolutely delighted to be introducing Associate Professor Lisa Whop to give this talk. She's a Torres Strait Islander epidemiologist and NHMRC Early Career Research Fellow. She's Australia's leading authority on cervical cancer control in Aboriginal and Torres Strait Islander women. Her work program focuses on cervical cancer control, including screening and vaccination for Aboriginal and Torres Strait Islander women. She brings research experience working with Aboriginal and Torres Strait Islander people, creating meaningful ways of engagement and community empowerment within an Indigenous research approach to direct her program. Associate Professor Whop has special interests in achieving equity by processes and outcomes in epidemiology, vaccine preventable disease, and translation of research into policy and practice. Over to you, Lisa.
Thank you so much, Emily, and I'll just get started by sharing my slides. Okay, great. Well, thank you so much for having me here today. I would also like to begin by acknowledging the custodians of the Ngunnawal Ngambri peoples whose land I'm on here today in Canberra, acknowledging their elders and their ancestors, both past and present, for their ongoing cultural connections in protecting this place that I have the privilege of living and working from. I'd also like to acknowledge the continuing sovereignty of all First Nations peoples who may be phoning in today, and for the lands where all the audience is from. I'd also like to acknowledge that right now, as we're meeting around the country, multiple rallies are being held calling to action a stop to Aboriginal deaths in custody. It always was and always will be Aboriginal land. Yes. As Emily said, my family's from the Torres Strait. I'm a Gumagal person of the Wagatagam tribe from Mabiag Island in the Western Torres Strait. I took this picture on my last visit home. These are my traditional lands where I'm a traditional owner. Biased, of course, but I think the most spectacular place in the world. But I was born and raised on the lands of the Walgarookaba Bindal people in Far North Queensland in Townsville. And I tell you who I am and where I'm from as part of a cultural protocol, but also to situate myself in the work that I do, the community I belong to, and who I serve. As distinguished Professor Aileen Morton-Robinson tells us, our cultural and social positioning informs how, when, where, why we conduct the research we do, as well as our disciplinary knowledges and training as Indigenous women academics. Our lives as Indigenous women are always shaped by the omnipresence of a patriarchal white sovereignty and its continual denial of our sovereignty. I say this because it's important to understand how I locate myself and the view in which I conduct my research, and how I've come to think about the title of this presentation today. I think about this in the way that I conduct my role, building on those that have come long before me and those who I know will come after me. So as Emily mentioned, I have a science background and trained as an epidemiologist, and I now lead a program of work focused on Aboriginal and Torres Strait Islander people and Indigenous peoples globally. I'm going to talk a little bit about that work a bit later on in my presentation. But I guess to start, I mean, we're really talking about research impact, and research impact is increasingly being discussed. I've heard it discussed over the last 2 days, and it really comes with many definitions. We're often being asked to, assess our performance as researchers against research impact, part of performance reviews, and of course, in recent funding applications. I know for NHMRC, the research impact counts for about 20% for an investigator grant. But I find impact can be an elusive term. It seems to bend and morph its meaning depending on different things in different disciplines and different fields and to different people. It means measuring it can be quite complex and complicated. And I'm not necessarily going to talk about that today, but I think it's important that we do think about it. It's often easier to see and possibly value the proximal impacts of research versus those that are more distal. So I want to give two examples today of this type of impact. And I'll start by saying what I know I'll finish with at the end of the presentation, that I believe that implementation and all that implementation encompasses is impact. I think it is the how. So implementation research, and I should probably start this by saying, I train as an EPI. I'm not an implementation scientist, but I have real deep regard for it. It's really created meaning to the work that I do. I think implementation research can be a concept that links research and practice to accelerate the development and delivery of public health. It kind of really helps me zoom out of just the intense work that we do, that specific project or those specific goals that we're trying to achieve, to really think about the big picture and how this fits in the world. Of course, implementation can be multiple disciplines and methods, and really emphasises the partnerships between community members, implementers, researchers and policymakers. And I know that we talk about this all the time. It can be very difficult to do. What I like about implementation research is that it focuses on the practical approach to improve implementation, but enhance equity, which I'm obviously very concerned with. But for us to think about our, efficiency as researchers, scale up and sustainability. So thanks again for having me and the organising committee. In fact, when I was first asked to do this talk, I was in Western New South Wales assisting in the COVID-19 vaccine response, a time when the implementation of research to maximise impact on health was as important as ever and time critical. So I'm going to use the rest of my presentation to share a bit about how, as Indigenous researchers, we came to be called up on for our learnings and some reflections regarding the impact that we were able to have in Western New South Wales as researchers working in immediate response. A sort of a more proximate impact example, and then finish the presentation with my sort of normal day job, thinking about the slow burn of cervical cancer elimination. So I know COVID's been a hot topic everywhere, but also at this conference. And, for the first 18 months, and I'm sure I don't have to remind anyone that there was really remarkable leadership, and there still is, from the Aboriginal community-controlled health sector and Aboriginal communities. In the first 18 months, there were less than 200 cases of COVID among Aboriginal and Torres Strait Islander people and no recorded deaths. The Aboriginal community-controlled health sector reacted very quickly and effectively to the COVID-19 pandemic. I think as Indigenous peoples, we quickly understood that public health measures and containment strategies and risk communication would not likely consider the socioeconomic, racial, historical or cultural context of Indigenous peoples. So it was really important that we were at the table leading and developing and implementing for this response. For me, the pandemic was and still is a reminder of the ongoing crisis of Indigenous health and the increasing threat that COVID-19 posed, or rather poses, to our communities. The vulnerability of Indigenous people appeared to be well understood, having been named a priority initially in the vaccine rollout. But it was those deep-seated and deep-rooted inequities in the initial the deep-rooted inequities that we have as a society that we became so accustomed to, our acceptance, our comfortability in incremental change in Indigenous health, that we hear each year as the Prime Minister hands down the Close the Gap report, that really has come back to bite us, for lack of better words. Those things like overcrowded housing, poor housing conditions, high rates of chronic disease, food and income insecurity, the social determinants, with all the research that we know has left communities like mine exposed. And while we're often described as a vulnerable population, I feel it gleans a sense of hopelessness and inevitability. But I really think it's about our collective failure to implement and have impact in ways that were required of us in the decades preceding COVID that has led to situations like that in Western New South Wales. So after great success and the vaccine rollout came to light, and of course, you know, there have been issues with supply and differing advice, delivery, communication. But when the first case of COVID arrived in Dubbo in early August, less than 20% of the Aboriginal population had had one dose of the vaccine, and only 8% were fully vaccinated. Since that time, there have been over 5,300 cases of COVID, with a majority in Western New South Wales and 13 deaths. It's the safe and effective COVID-19 vaccines were developed in record time. I'm sure that many of us in the early months of last year are really not necessarily surprised, but to have such a safe and effective vaccine so quickly is a remarkable feat. But sadly, it's a really good example that discovery and innovation are not always enough. Developing the vaccine was one hurdle, but sharing the vaccine equitably across low and middle income countries and of course within countries has presented massive implementation challenges. So to assist in the urgent distribution of COVID-19, an AUSMAT team was deployed. So AUSMAT, our Australian Medical Assistance teams, are often used in an international setting. This is the second time in their history they've been deployed in a domestic setting. And their task was really to provide vaccines to vulnerable populations, Indigenous peoples, and those who otherwise would not access a mass vaccine hub. To assist this AUSMAT team, an ANU team of Aboriginal and Torres Strait Islander people, including myself, Dr. Jill Guthrie and Tamara Riley, were asked to support the efforts. So we're pictured here with the Indigenous Specialist Liaison team, as we have come to know, and also with the AUSMAT Alpha team. I'm going to share a little bit about some of the lessons we learned in the field. So this team, or our ISLT team, were made up of experienced Aboriginal and Torres Strait Islander researchers with expertise working with communities. So we really understand community and stakeholder engagement. We have expertise in public health and epidemiology, but importantly, we understood the importance of cultural safety, especially in an emergency situation when there's distrust of governments. Some of our role included, pre-engagement planning, being the conjoint between multiple stakeholders involved and the community. I have to pause to say that this all came to light in about 3 days, and it is a real credit to the ANU and to AUSMAT who made this work, and of course this was supported by New South Wales Health and the Commonwealth. But I think for the ANU to release researchers so quickly and support us to do this work that was so important for community is a credit to them. So I just want to share some models that we developed. This first model, a high impact model for engagement, we developed pretty much at the back of an envelope on the way back, one day in the car, really trying to clearly and very simply identify the key parts of success. So in this model, we talk about context, so context including the political, social, economic, historical, relational, environmental factors. For example, relational was very important in this setting. Some of the communities we were going to had strong community links to Wilcannia, which I'm sure many of you would have seen the 7:30 report last night and have followed that story. The evidence part allowed for us to understand what needs to be done, including looking at the data to see who was not accessing vaccines, what age groups, for example. And then, of course, community. So involving and understanding what their priorities were, what their goals were, and how they would like things to run. And of course, having a surge capacity workforce in an emergency situation was really important. But I also believe it was our capacity as Indigenous researchers who were used to working between community and government that was able to kind of really make this so successful. So when all these components were utilised, we were able to target the priority population and achieve high impact results. So this second model is a high impact vaccine delivery model. This was definitely not the model when we first hit the road, and it really came as we worked and understood how our community really needed us to be there for them. So the idea was that we would always want to deliver culturally safe vaccine delivery. So this diagram, of course, context is there. Context in this scenario, a bit different. So understand the community, local customs and the ways of being, knowing and doing. And just understanding how the community runs. The three-pronged approach to vaccine was about having a central hub, delivering the high volume of vaccines. But of course, people who turn up to a vaccine hub have already made a decision to have a vaccine. So we had to augment this with a health promotion and a transport service, which we named the Vax Bus. So we had people go out, public health doctors and nurses, and talk to people with the Indigenous Liaison support team and local Aboriginal people who we'd teamed up with in that pre-engagement. And just go and have a yarn with people over the fence, talk to them, answer any questions. If they wanted to go to the vaccine hub, we could provide transport. And if not, we could make a note and provide a mobile delivery. So that mobile vaccine outreach, I believe, really changed the power dynamics of how the conversation was viewed. It wasn't necessarily about delivering the vaccine. Of course, that was the impact we were hoping for. But I think for me, it was really about how we delivered safe information where people could ask questions. This really proved a successful way to community, but also for the safety of the Indigenous Liaison support team and also for OSMAT. So this is just an example of, I guess, the models in practice. Or in action. So we had the privilege of going to Namatjira, which is an Aboriginal reserve in far western New South Wales. It was here that we worked alongside the CEO of the Land Council, Auntie Pam Handy. We decided in the end to set up the hub at the local Land Council office. It was a place that was really highly accessed by community, a safe place. And we were able to let the community know through trusted community members who we were and why we were coming before we went there. But of course, context is everything. We were able to have a welcome to country performed by Auntie Pam, who was providing some history into the local area. And she was telling us that in the late 70s, up into the late 70s, that government cars, white government cars would come into the community and take children. And I just remember thinking, this is all going to go down the drain because we had arrived and driven all through the community in 5 white Prados. We really quickly had to reassess where we put the cars, for example, and while we thought everyone would come to the vaccine hub, and many people did, a lot more didn't. And I really believe it was because the way the cars rolled in the morning. So we did a lot of door-to-door knocking, and we had a really successful 2 days in Namatjira, which was really lucky because 4 weeks later, COVID had arrived. Namatjira provided an example of how these two models really came to provide a maximum impact. We were able to retain our cultural protocols, but it really demonstrated how important trust and engagement and relationships are for implementation. So when I got home and entered quarantine, I had a lot of time to think about the impact we had. I think, the example of heading out is not necessarily a research example, but it's researchers utilising our skills in that sort of setting. It demonstrates very quickly how impact can be achieved when there's political will, dare I say survival, resourcing, stakeholder and community engagement, multiple sector involvement. But I think the key part was that it was a shared goal and a clear vision. We understood, everyone knew their role in achieving that same vision. Many of these things on this list are things that I strive to do all the time in my work. And it takes a lot of work as researchers, I'm sure you can all appreciate, you know, to get governments interested, or to get the right resourcing, or to get the stakeholders engaged. And this scenario was such, with COVID response in Western New South Wales, was quite different, because all of those things were on the table, and it was just about making sure things were implemented in a way that reached the community. So I just want to change tracks now and go back to what my normal job is, which is actually working and thinking about the elimination of cervical cancer. You know, it's a bit of a slow burn. We know that research is a bit of a slow burn, and I'm really lucky to work in the elimination space. I won't go into much details around cervical cancer, except to say that it's highly preventable, and we've had so much rapid knowledge discovery, innovation, and technological developments. It's quite remarkable. But it truly is a disease of inequity. And the World Health Organization last year were able to launch a strategy with a vision to eliminate cervical cancer, which is pretty amazing. And it has 3 goals there, which I won't necessarily go into, but you can just see that by achieving these goals with this concerted effort, we would be able to avert, you know, large numbers of new cases of cervical cancer, and of course avert many, many deaths. So with all the technology and all the innovation and all that we know about cervical cancer, it's sad to say that globally it's Black and Indigenous women who continue to bear the brunt of an almost entirely preventable disease, despite knowing so much about it. This is really where implementation and impact, I think, can be discussed in a little bit more of a distal way, in that sort of slow burn. So here in Australia, while Australia is a global leader in cervical cancer, expected to be the first country in the world to eliminate cervical cancer, that won't be a reality for Aboriginal and Torres Strait Islander population, and that's the work that my group is focused on. You can see here on the far right hand, Australia and New Zealand, very low rates of cervical cancer incidence. And I've just plotted where Indigenous people sit. And you can see that it's much more comparable to low and middle income countries that don't have access to the vaccine program and screening program that we do here in Australia. Really a stark reminder of inequity. So I thought a lot about what I would say today, and I have to say I went round and round, but I thought perhaps what might be most interesting is just to show you how I've come to do the work that I do. You know, I started with a PhD in epi, trying to quantify why women, you know, the screening differentials as a contribution of why we see such high incidence. And that gave me a great piece of the puzzle. And that's really how I see research. It's really just a piece of the puzzle. And I'm very clear about what the picture on the back of the box looks like. And for us, for our team, that's about ensuring elimination is reached for Aboriginal and Torres Strait Islander women. Having this strategy has allowed us to understand what role and what piece of that answer and the stage that we're at, that we're in. And so every person in the team knows what part they're contributing to, for what target and for what ultimate vision. So this is just, actually, it's a bit old, a snapshot of the way in which we've set up our research program so that it focuses from, you know, HPV vaccination through to treatment. But I just want to highlight the advocacy, which I'm not sure is the right word, but I guess it's how I see it. This is about giving us as researchers permission to do the stuff, the impact that we think is important. That might be going to community meetings, that might, and just finding the money for it. That means doing media, doing presentations to lots of different people, doing the strategic policy advice like the guidelines, etc. But we see it all as part of an equal part of how we contribute to solving this problem of inequity here in Australia. So just as an example, we've had the national screening program for since 1991, and one of the major issues has been that lots of women do not like to have a clinician to take their cervical screen. So a speculum examination is one of the major barriers. With all the information and innovation that we've had, in 2018, we were able to introduce into the screening program an offer of self-collection, which means a person can take the sample themselves with a flock swab. And while it had a little bit of a restricted access about who could do it, it really was targeted at people who were not currently using the screening program. But since 2018, there's been less than 1% of eligible women who have actually used self-collection. It strikes me as just such a clear example of implementation failure, where we actually have resourcing, technology, policy support, all the evidence to indicate that it's highly acceptable, and yet it's not being used. And so there's something there that really is a missed opportunity, and some work that we're going to be working on. So where to next? So just in terms of say we just take screening, we can just think about, I've done the epi work. We've done a lot of qualitative work about what women actually want. We've done a lot of the strategy, the guidelines, etc. And really it's taken us to this point. And this has been about 10 years of collaboration and contact with community. And they came to me and said, we want to do what works for our community. And so that means my beautiful step-wedged cluster randomised control trial doesn't work. It means that an implementation trial where it's led by community is the answer. And so that's what we've put in for a grant that's currently under review. So just to finish up, I'm conscious of time, that this is a theory of change that we developed that really takes the example of screening. It allows us to think about how a particular way of working will be effective, showing how change happens in the short, medium and long term to achieve our intended impact. I find theories of change very useful, and I know that a lot of researchers will go, oh, that's not for me, it's highly complicated. I drew this out initially on my whiteboard and had someone else make it beautiful, but it's helped me really consider all the moving parts, all the stakeholders at what point need to be engaged. And I found it a really great tool to invite stakeholders to contribute to this vision. It's allowed them to become part of it, know their place and know what we're trying to achieve specifically for this project, but for afterwards and what it could contribute to into the future. Implementation is where I've found and felt the most useful. It's also where I've found the discipline I trained in EPI to be the most useful. I don't think it's an either-or thing. I think that we can all think about the tools of implementation in whatever area of science that we work in, to really think through how we actually make sure that impact comes from the work. And I do believe that implementation is the way that we do that. So in finishing, really, I see implementation about strategies, plural. It's not just about one. It's not a linear process. It's not about getting to the end of the research project and hoping someone will take things up. It's about how we kind of adopt and integrate evidence from research right from inception. So we know we can have, clinical guidelines, policy briefs, the committees, Twitter threads. I'm a big fan of Twitter, and getting our word out there. But it's not necessarily just about research dissemination. And I think that is often where we get caught up. So I would stress that we'd like to think about, implementation from our inception. That should be the goal. That is what will help us create maximum impact. To think through the world, the real world settings, the acceptability, the application. I think about this a lot because I know that I'm working within a space that is improving Aboriginal and Torres Strait Islander health in a society that really, kind of a racial environment. And so the research setting doesn't necessarily reflect what the real world setting is. That diverse skills bring so much opportunity for greater impact in ways probably beyond how we would think just on our own. And I think it's really important as researchers to understand both the proximal and distal impacts we can have. And I think a clear research vision really helps. So just in finishing, I guess just to say that implementation of research really allows us to think about that broader social, historical, political, environmental and cultural world, rather than just adjust for it. It requires a real commitment to solutions rather than focusing just on problems. And I love that about this work. It gives us a real clear line of sight of what pieces of the puzzle we're working on and what is missing. So I guess in finishing, my closing question, because for me, who I'm in service to is very clear. I'm not in service to the Institute or the Academy. I'm in service when I go home to the Torres Strait. And so I'm very clear about who and why I'm doing this research, and I understand very clearly what impact means for them. So my closing question to all of you is to think about who are you in service to and what would impact mean for them? And I'll finish there, Emily. Thank you.
Thank you very much, Lisa. That was an absolutely brilliant talk, and it was really heartening and I think a privilege to see all of that work that you're doing on the ground, informed by such solid science. Now, we've got a little bit of time, so I'd like to invite any questions from the audience, but in the meantime, I've got a couple of burning ones myself. I know that we're all here to have impact. Every single one of us in this academy, every single person watching wants to have impact. But quite often people are thinking, where do I start? And I'm wondering, you've put out that provocative question to us about who we are serving and what implementation means to them. Is that where you would want people to start? Where should people start if they're thinking about maximising impact?
Yeah, I mean, I don't know if it's where people should start. I think it is. I mean, as Indigenous peoples, locating who we are and where we're from gives us an understanding of relationally what our obligation is to community and family. And so that doesn't leave when I enter into my office of a day. You know, I think that being really reflective about what you bring to the work and why you're doing the work is a really good place to start. And it's okay that we all want to have successful careers that are rewarding both individually and collectively. I think, though, that we often get really stuck in just thinking about what we think will be the best, you know, the best next step or the best impact based on our expertise. And that's important, but it's only one part of the puzzle. And so I find it really grounding to know, you know, who I am and where I'm from, because it helps me understand what the type of impact I need to be prioritising for my work. So I guess, yeah, that is a good place to start.
Thanks so much, Lisa. We've got a question from Elizabeth Elliott, who says, great talk emphasising the need for Aboriginal community consultation, leadership and engagement in research. How can we persuade funders that this takes time and money?
Well, if someone figures that out, let me know. Yeah, it's really hard. I think that we can. I think we're slowly getting there. But, you know, this, as I said, you know, and it's hard to measure the impact, which is what I've been thinking about through this talk, as, you know, I could do this community-led intervention I talked about at the end of my presentation, you know, without any, you know, very small, maybe a year's worth of consultation and still create impact. But I know that having this 10-year lead up to this project means that the impact will be so much greater, and not just in terms of effect size, but I think in terms of the experience and the safety for mob to participate and, you know, be architects of the world that they wish to live in, rather than being told what to do. I don't know how we can convince funders, and I'm not necessarily sure that's where my time should be placed. I think we should just do it because it's actually just the right thing to do, and hopefully they'll catch up.
Thanks, that's fantastic. So a question that's been in my mind over the couple of days that we've had this meeting is that implementation and translation and impact are viewed really differently according to different disciplines and models. And I very frequently see, in fact, the last talk, we see quite a linear model of translation where it sort of goes basic science to drug discovery to the clinic, really. And so there are linear kind of pipeline models. Sometimes they have health services in them, but they are really quite linear. And I think there are other disciplines who really view, well, science itself is not linear, but also the process of getting impact as being a non-linear, more of a complex adaptive system. I'm wondering if you could comment on that, but also if you could comment on how on the impact of using the different models and what that means for people like you.
Yeah, sure. Yeah, I think there are some examples where it will be linear, or I think retrospectively when we think about a research project or a program, we just imagine that it was a linear, we did this and we got this. But I think if it's in the process that I think is where the magic happens, and that's why I think the non-linear model helps for that, because it means that we can refine and perfect as we go, and that might change the trajectory of where we could have been. So I think using things like a theory of change model helps us really to visualize who's involved and who needs to be there. But it also means that something might change and we can go back to that model and refine it as we go. I think if we only expect something at the end and have no vision in the middle, then we really lose the impact through the process. And I think that impact via process is actually just as important as the impact at the end of a research project. So I'll leave it there, Emily.
I just had one final question, Lisa. You'll forgive me for this. We've also had a theme running through the meeting so far that we can make generalisations about populations, but we also really need to be thinking about different groups within that population. So we've seen that about COVID control, we've seen it about COVID vaccination. And I know that Australia is a world leader in cervical cancer control and was actually really celebrating being able to eliminate cervical cancer. And then you were pointing out that, can we really say we've eliminated it when we haven't eliminated it within our first Australians? Can you tell a little bit about how you had that conversation and how that conversation played out on the world stage?
Thanks for that question, Emily. I'll be really honest. 10 years ago, or even so, that was definitely not the conversation. Inequity was not the conversation. It was about the vision and leadership of Australia to achieve elimination first. I think most of us probably can agree Australia is quite obsessed with winning and being at the forefront, and I just think it means nothing unless we've eliminated for all populations in Australia. I think that it says a lot about us, actually, if we claim elimination without including the vision for all populations who live here, including, of course, a connection to, the oldest continuing culture in the world. I think that does say a lot. My tactic has been to be present all the time, and that has meant that it probably has impacted on my own research output. It means that I have to be at all the meetings and all the conferences, because I think what started as sort of me being a little bit of an annoying voice, and not saying I'm the only one, because there's lots of people who've worked in this space, but just as that kind of annoying reminder of like, oh, actually remember this. And now the conversation's totally changed. It's awesome to see, where we really see in every way that we talk about elimination, it's always by saying we'll achieve this as a population, but we have a lot of work to do in terms of ensuring that is met for Aboriginal and Torres Strait Islander people, but also now that our role in the region, given that we're surrounded by countries that have some of the highest rates of cervical cancer in the world. So I think that's sort of that distal impact, right? It's being there, showing up, that slow burn, and then suddenly all we're talking about is inequity, and yet I know that took a lot of work. That's probably not easy to quantify in a way that funding bodies or, performance reviews would measure very well. So I hope that's okay.
Thank you very much, Lisa. And I think you've really captured there another way that research has impacts, which is researchers having impact. So thank you very much for a really fabulous talk. I know that everyone will have found it really inspiring, and sometimes when I'm feeling a bit sort of down about some aspects of research, I think about you and people like you, and I know that the future is in safe hands. So I know also that there would be a resounding round of applause if this was in an auditorium, but it's not. But I think you just know that everybody is applauding you now.